can hear me just fine. Let me just start our recording so you guys can have this later on if you want. You'll notice the chat box down at the bottom, so if you're having any problems hearing me or Dr. Russell or Wayne, please let us know. But we'd like to welcome you to tonight's webinar on the N-Force Fixation System presented by InnoVision. We hope that all of you that are in the mid portion of the states are staying safe. It looked like everybody was getting some snow or significant amount of rain. You know, we really appreciate you guys in what you're doing. We know that you're the front line for InnoVision, and so we just want you guys to know how much we really appreciate you, and we appreciate your time tonight. We hope that you'll find this discussion quite fruitful. Tonight we're very fortunate to have Dr. Toney Russell speak to us about augmented fixation. As you know, I'm Dr. Tim Brown, and we have Wayne Ritchie, the Vice President of Sales for InnoVision. After Dr. Russell's talk, I'd like to turn over the discussion to Wayne, and we can talk a little bit more about sales. This is a family meeting, so we want you guys to ask any and all questions. Just some housekeeping thoughts. We're using a program called Click Webinar. It's a fairly new service for us, and so we hope that we've worked out all the bugs, but please give us some feedback of how you think that's working. And because this is a webinar format, we've muted everybody else's mics and web cameras. We found that it gets too chaotic if we get too many mics open and too much feedback, but we really want to encourage your participation in this. And again, down in the left lower corner is the chat box. Just feel free to type away, and we'll keep track of questions. Some of the questions we may answer as we go. Others we may want to save to the end and open up for some discussion. So Dr. Russell typically shows some videos throughout his presentation. Because webinars are a bit in the infancy still, we found that it's easier for him to go through the presentation and then show the videos afterwards. So we'll show you all those. Tonight's subject is about peri-articular fractures, why a significant percentage of these fail, and really what we can do about them. So without any further delay, let me turn it over to Dr. Russell.
So let me see if I'm on. Tim's got me all hooked up here. I want to thank you so much for tuning in again tonight. The real purpose of this thing is to give you guys some basic information and really what we're trying to do with the N-Force system in conjunction with ETEX and all of their materials. And it's really kind of a challenging task because you've got a whole bunch of people out there that have been complacently doing the same old thing for years. And we're going in and telling them, hey, there's something better. So it's kind of an opportunity, but it's also a little bit of a struggle to get people motivated to kind of understand what we're talking about. So part of this will tell you how we got to where we are. And the, see what the next talk go. Get it to move. Yeah. The first thing we kind of got to review is what bone really is. And we talk about bones all the time with nails, and we talk about how the bone heals around the nail. We talk about plates and screws, and we basically talk of plates and screws as you kind of put a plate on and the bone kind of connects underneath it. But if you ask surgeons, they don't really think about this most of the time. And if you look at this little schematic here, we got a bone, you really have this tubular portion of bone in the middle that we treat with nails. But this metaphyseal bone that you see up in this area, it's always at the top and at the bottom are the proximal and distal ends. And it has this kind of architecture. It's we call it a trabecular pattern. It's a network that has really a cellular network. It has defense mechanisms. It has blood vessels that go through in certain areas. So what we're trying to do with the bone grafting or the ceramic bone replacements is to actually give material to reconstruct this trabecular network. Now, this cancellous bone has a compressive strength of about 10 to 12 megapascals. And this is kind of like a hard styrofoam. And the strength comes from the way these trabecula are oriented. So that's kind of, keep that in the back of your mind when we're thinking about these replacements and what to do. So when we have these fractures, it's not like a clean break where we think of the middle of a long bone that breaks into two pieces. It's actually really kind of a blasted thing, that there's 4 or 5 large fragments maybe, there's a bunch of small fragments, but there's a lot of impaction or crush injury as well. So these peri-articular metaphyseal fractures are the ones that give us all the trouble. You think about it, it's distal radius, it's proximal humerus, it's the elbow, the fractures about the knee and the ankle. And if you look at this trabecular bone pattern stuff, this is normal bone. So there's our kind of a coarse, type cellular material, kind of a coral type look. But if you look at the osteoporosis, you can see why in the people over 60, these fractures are even more devastating because there's less bone mass. They don't have as much compressive strength. And so these are more prone to having more damage and more collapse when they sustain these injuries. So if we look at the hip, which is another big area that we're going to tell you more about, that we'll be going into here hopefully in the fall, but the hip is one of our biggest problems and challenges because, again, we have this architecture of this cancellous bone pattern, some areas of actual voids. If you look at this model, you see this is actually called Ward's triangle, where there's no bone at all. And so when we have these breaks that go through here, they can actually have just a rim of bone left. And so a lot of our internal fixation failures are because of the bone material that we have to deal with. If we look at the knee, the same type pattern. And so kind of at the end of this talk, I want you to walk away thinking bone's a lot more like styrofoam than it is a piece of oak. So you look at this trabecular pattern and again realize that this is good bone. In these older people, this bone can be even much less, have much less calcium trabecula and have a more void, capacious type bone. The ankle, calcaneus, same type of bone. So you start seeing a pattern here that anytime we have these cancellous fractures, that's an opportunity for ceramic or cement augmentation. Distal radius, this is just showing some MRIs of, again, that porous nature of the cancellous bone. In proximal humerus, same thing. And if you look at our failures in proximal humeral plate fixation, it's pretty much always where the screws penetrate through the bone or the thing doesn't heal and the screws just break or pull off. So we haven't solved these problems like we thought we would by now. And if you go back and look at what are the main thoughts that's driven surgical treatment of fractures, it was the idea that in 1902 that they started x-raying things, and they said that when the bone got back in position, the functional recovery seems better. This was kind of propagated from the British Medical Society, on the con, the Belgians, Lambot, Denise, and then Lane, and they started all looking at this idea of, hey, the closer we can get the anatomy back, the better. And in fact, the area was founded on these 4 principles as far as what you need to do for these metaphyseal fractures. And it was an anatomic reduction of the joint, that was first. You have to have stable fixation. They initially said rigid fixation. And that's because you've got to hold this thing still enough that the bone can grow together. You have to preserve the soft tissue and the vascularity for it to heal. And then if you do all these things right, the idea is that they'll have less pain and you can move the joint or rehabilitate the patient much faster. So that's kind of our overriding goals, and that's really the principles of internal fixation. So if you look what we've been doing for the last 30 years, it's pretty much been focused on trying to increase the fracture stability in these metaphyseal fractures. So we started out with lock plating. Then we started doing the hybrid lock plating, where you have some locked and some not locked, polyaxial lock plating. And all these things are basically saying is that we're not getting fracture stability with a regular screw. We're not getting fracture stability with a regular plate and screw. Can we make it any better with metal? And we've been a little bit disappointed that the locking plate technologies have helped, but when you stack it up against the osprey bone, we still have a problem. And these plate failures are really kind of evidence of the loss of bone that you have when this metaphyseal bone is compressed. And it's really an insufficiency. The bone has been damaged to the point that it can't regenerate itself. The bone can be so weak that the internal fixation actually just cuts on through, like you see in this hip fracture, and the patient has to have a hip replacement. Same thing where you'll either get plate breakage if these don't heal, or you'll actually see the screws, these locking plate screws, break at the plate bone interface. So we're still facing a lot of challenges here. And so the real question is heavy metal the answer? Because, you know, if you look at these things, we're trying to put more and more metal in there to replace the bad bone. And it seems like it'd make more sense that we need to augment the bone rather than just put more metal in. So the idea is that can we change the use of ceramic cements instead of just a bone void filler? Can we actually use it to augment implants so that we don't have to use as much heavy metal, and so that we can actually get a better interface with the bone? And then this might actually change the way these things heal. So looking at these fractures, there's a lot of opportunities for ceramic or cement augmentation type devices. So if you're ever in the operating room with a guy and he's got these metaphyseal trabecular bone insufficiency problems, you're going to hear him use terms like "this bone sucks," that's the TBS phrase, DLB, the darn lousy bone. And the idea is that he puts the screws in, he can't feel anything. So then he doesn't let the patient move. The patient gets stiffer. Because they're not moving and weight bearing, they get more osteoporosis. And so you end up a year later, the patient has a stiff joint, they're weak, and the bone has not really recovered its full strength. So that's the challenge that we have right now. People have tried for a long time of filling these holes or these metaphyseal fractures with cancellous bone. And this is the biggest challenge you'll have talking to doctors, because a lot of them still believe that this is what you're supposed to use. And the bottom line is there is no literature that supports the use of bone chips. This is a paper that says if you pack it in as best you can, you get 1/10 to 2/10 of what you need. So it's 10 to 20% of the strength that you need. So it just doesn't work. And there's multiple papers, and we can provide those for you, that you can show your doctor that we've done mechanical testing. People have done all kinds of testing. Cancellous bone chips do not structurally support these voids. So this was a nice study done mechanically up in Nova Scotia by Andy Trimholm and Ross Layton, and they made a tibial plateau model. They left the hole open, and you can see that it collapsed as soon as the patient moved. If the patient got packed in cancellous bone harder than you could ever do it at surgery, then the thing would still displace up to 5 millimeters before they could even try to walk. But when this new materials, this is alpha BSM, which was the progenitor of the calcium phosphates that ETEX has, it actually was the closest thing to give you enough stability to get the patients up, moving, and getting a little weight on their legs. And so kind of a way you might conceive of this, telling your doctor, is that you can take potato chips and stuff in a bag as tight as you can, but as soon as you put any load on them, they're just going to crunch down. And that's exactly what happens to cancellous bone graft. So here's the second problem with putting in dead bone graft. The dead bone doesn't really attach to live bone. So you get an inflammatory reaction that actually remodels and takes away this dead bone, and it may take up to 7 years to remodel dead bone that you put in the body. So this idea of bone graft substitutes has been really going on for about the last 30 years, and we call these ceramic-based. Y'all have heard a lot about this. I want you to start thinking about these ceramic materials as implants. And I'm going to show you in this talk why this is important. They are not Play-Doh, they're not silly putty, they're not DAP. So when you put these things in, just like an implant, It's got to be the right material in the right place in the right quantity. And so we're going to show you some examples of this. This is a paper that most of the cements that are out there on the market are derivatives of either amorphous calcium phosphate, which is the ETEX products, alpha tricalcium phosphate, and beta tricalcium phosphate. And why that's unique is that if you look at this list, about the only folks that use the amorphous calcium phosphate is ETEX. And they really have a pretty cool proprietary way of making this material, which is why it's so different. And this has now been proven in multiple animal and human studies. And this is from Dr. Tom Einhorn, who's the chairman up at Boss U, in a JBS review in 2008. He said, you know, first of all the calcium phosphate cements are not the same. And this is what a lot of the competitors have been doing, is they've been trying to say, whatever white powder we got, they're all the same. So it doesn't really matter, doctor, what you need. And there is just no truth to that statement at all. It's a marketing ploy. So how are these things really healing? I want to change the way you think about bone healing. This is from Dr. Welch down in Parkland. And he published this in JBJS in 2003. And he used a goat model, which is, you know, very similar to humans, actually, the larger mammals, and created a plateau fracture. He had trauma surgeons from Parkland do the surgery, so they packed graft in. And this is some of the examples. So this is a microscopic section. This is the knee joint. This up here is the articular surface. This is the articular fracture they created. This is the ETEX, the calcium phosphate cement that you see here packed in. And this is bone graft. So this is autologous bone graft, and I want you to notice the first thing. This is 24 hours after surgery. The articular reduction has collapsed. Now, your doctor is going to say, no, that can happen. Well, here it is. This is proof. And what happens is that bone graft they put in there compressed down further, just like potato chips. And if you step back and look at this picture, this little lacy network, this is the trabecular pattern. And when you have the fractures that break this up, this trabecular pattern has to be regenerated. And just packing in chips doesn't give you the structural strength that you need. So the ceramic cement has much better compressive strength, and so it'll hold up to this load. What happens a little later? Well, this is at 6 months. In 6 months, our articular surface is still lined up nice and straight. What we see in the bone graft group is collapse of the articular defect. This will lead to arthritis, not just on the tibial side, but also the femoral side that's supposed to be articulating here like this. And you look, this one actually had a void. So the graft material was actually completely removed as dead material and left a hole. So it's structurally not regenerated. This is what it looks like at 18 months. This is the alpha BSM, which is the precursor of the beta BSM and the CarriGen. And what you see is the cement is gone. And what's happened, now we have these nice healthy trabecula again. So this material helps regenerate on normal trabecula. And as it gradually has this cell-mediated resorption, the articular surface reduction is maintained. So this actually can heal the way it's supposed to. Now, we did this study. This was published in JBJS 2008. It's the only level 1 evidence for any calcium phosphate cement that's really out there, comparing it to autologous bone graft. And we found the very same thing that we saw with the goats. And that is, you know, we got a group of people that are all tops in their field. They're trauma surgeons. They know how to do this stuff. We did the tibial plateau model. What we found was there was a trend to better range of motion at 6 months and 12 months in the group with the cement augmentation, not the bone graft. So again, relating to the stability issue. This is what we found in the bone graft group. And here you see this is the reduction. Everything looks okay for right now. Patient gets up and starts walking 3 months, starts having pain. And what you see here is collapse. So this is how much this plateau collapsed down. And you look at this, you see this sclerosis, how white this is? This is normal Hensel's bone over here on x-ray. So what has happened is all that dead bone just scarred in. And so we really don't have regeneration of the normal trabeculum. What we found in the study is that 30% of the bone graft group, you can actually tell within 3 to 6 months that the reduction collapsed. So that's a 30% failure rate. 9% of the alpha BSM group collapsed, but these are cases where there was less than 5 cc's of material used. So this kind of got us thinking that just like implants, you got to have the right number of screws and a big enough plate. You've got to have the cement in the right place in the right quantity. So now if the doctor says, well, I do fine with bone graft, you can tell him there are 4 level 1 studies in the literature saying that calcium phosphate cements are better than bone graft. And the big push these days is to be basing our treatment on science. And so this is good science. So they're going to push back on you and say, well, what kind of ceramics should I use? I use this guy on Tuesday, and I use this guy's white powder on Thursday, and on the weekends I use this guy's powder. And you need to kind of change them and get them to think about the different types of materials and what they are, because they are not the same. So this is a good example. Early on in the 1980s and 90s, we were starting to play with calcium sulfate, which is plaster of Paris. And this is a tibial plateau. You can see here's a big defect up in this area. You see, that's a big old hole. This is the articular surface down here. So that's how far it's been pushed down. So this was Dr. Watson gave me this case. So he reduced it nicely, and you see this white material right here is calcium sulfate that he put in there. So it looks pretty good. The trouble is calcium phosphate is a salt. And so what it does, it just dissolves away. So at 10 weeks, the cement dissolved away and the whole articular reduction collapsed. So the calcium sulfates are not strong enough to hold this reduction. And this was done in a meta-analysis study that we published, again, 2008, and showed that calcium phosphate cement, not the calcium sulfate, had better fracture reduction maintained and lower incidence of pain. So again, level 1 evidence that these guys should be changing to the ceramic cements. Well, this paper from McDonald was published in JLT in 2011, and it said, hey, the cement's got to be in the right place, and it's got to be in the right quantity, which we kind of learned from the study in 2008. And they said if you have a cement that sits up really fast, we call those exothermic cements, and these are like Norian from Synthes and Hydroset from Stryker, is that those things, if they sit up in the joint, you've got to go in there and chip them off. So the idea of having a cement like the ETEX products that doesn't sit up too fast is actually a real advantage and a safety issue. Now, this is a good example of talking about this not putting material in the right place and the right quantity. So this is a recent case from here in Memphis. It says tibial plateau fracture, as you can see here. Here's a CT scan. You can see, this is obviously a plateau fracture. There's a big, articular problem right in here. And here's all the pieces kind of right in here that we've got to get back together. This is the side view. You can see how the fracture's collapsed. The joints are irregular. So you got to put all these pieces back together. Again, you're looking at these articular pieces. This piece here needs to be up here. This piece here needs to be up here. And this needs to come over here to restore the joint. So this is the surgeon's treatment. And you see he got a very nice reduction through here. See, that's a nice replacement of the articular surface. He's got everything lined up straight. But if you look at his cement, the cement is down here. It's not up here. And you need the cement right up against the joint. On top of that, if you look at this, there's something kind of sticking out here and here. What is that? Some extra cement? Well, this is the patient comes back at 2 weeks. At 2 weeks, she's collapsed. So he's lost his reduction, and the tragedy is he can't do anything about this now. It's gone. So she's going to get arthritis in her knee because this construct didn't hold up. And if you look at this, you can see what happened. The joint, this is the medial side, the fracture that was broken collapsed right down like this. It fell right back in place. And this is Norian cement that's outside the joint. So the cement was not kept in the right place. And it wasn't put up here because the surgeon was trying to stick it with a needle or a cannula, and he can't get it in the right place. So again, the right material in the right place in the right quantity. So this is the way we started out doing it, and this is the alpha BSM study. We'd actually open the fractures up, put the surface, and actually pack this stuff in by hand. And the problem is, if you had a very accommodative fracture, you'd actually destroy the joint trying to pack this in. So we started moving more to injection. And this is when we found out that when you try to inject these materials, you lose a lot of your material. You can't tell if it's in the right place. And it's similar to putting too short a plate on with not enough screws. You know when you're doing it, it's not going to work. And we actually did a VJO, Video Journal of Orthopedics, kind of showing the different ways and what the problems were. So what's happening now? Well, now we've got this opportunity to actually start using the implants as a delivery system for these advanced nanocrystalline calcium phosphate cements. And if you're going to the hospital and tell you guys, well, why is this important? Well, first of all, we talk about surgical efficiency and reproducibility. If I give a surgeon a paintbrush and some paint, and I say, hey, I want you to draw me a picture, there's going to be different pictures everywhere. So the idea of surgical instrumentation is to be able to let the same surgeon do the same operation the same way every time, and let that guy in San Francisco do it just as well as the guy in New York and just as well as Tampa. So you need a technique that gives you a reproducible result. When you're fixing the fracture, you have to have construct stability. You've got to get the pieces back in place, and so you've got to hold them there until it heals. If you do that right, then the idea is that your patient outcomes are going to improve. When patient outcomes improve, you have value-added technology. So we're actually letting the patients get a more reproducible result, better range of motion, and getting them moving sooner. And the whole key to this with the ceramic augmentation is tissue regeneration. We're not trying to fill it up with a bunch of metal. We're actually trying to regenerate the trabecula, just like you saw in the goat study by Welch. So this is, Dr. Phil Proctor gave me this model. This is a model of actual cancellous bone, and this is showing what a normal screw looks like in cancellous bone. This is a 6'5" screw, and this is what it looks like. And what we really want to do is have this picture. And this is a concrete block with concrete, and there's our rebar in the middle. So we're moving to rebar as our model for fixation in these metaphyseal fractures. People are starting now to pack things in. This is from a group in Switzerland. They're packing Norian around these screws. So it's already starting to come. What we're doing is we have the first FDA cleared implant that function as an injection mechanism. So why is that important? Well, we talked about reproducibility and efficiency. If I put these screws in, whether I'm in San Francisco or New York, the cement's going to come out these screws the same, and I know that I'm going to get a reproducible cement column around the screw. So I'm not going to lose this valuable implant because it's messing out in the field. And we'll show you some examples of this in the video. So this is what the screw looks like. And it is, like I said, the first US FDA cleared combination device for a biomaterial and an implant. So we got a little head start on the other guys. It's basically a cannulated screw that you use, but there's a partially cannulated design. So if you have to go bicortical, you don't have the cement coming out in the soft tissues on the other side. The instrumentation is just like any other cannulated screw system. There's a screwdriver and K-wires and a drill, depth gauge, and skin protectors. That's pretty much a cannulated screw set. So the only thing that's clear for use of this screw right now are the ETEX products Beta-bsm and CarriGen. And so what are these things? They're slow-sitting metallocalcium phosphates. That's a mouthful to say that this stuff is the closest thing to human bone mineral crystals. So it beats everybody else, and there's enough literature and science to prove that as a true statement. So why did the FDA clear these new materials and not the other ones? Well, there was a whole risk profile of ceramics that we're looking at injecting. They didn't want us to kill anybody. They didn't want us to cause any problems in the future as far as reconstruction. So the real reason that these two materials passed is because they met the safety profile the FDA wanted. And the other materials just didn't look like they had the literature to pass. So we basically have this partnership with ETEX that we're supporting them and they're supporting us, and we appreciate that greatly. The really cool stuff about this material is that it has a cell-mediated resorption, which is the same way bone mineral crystal is normally handled. You have osteoclasts that come in, digest the material, and then you have osteoblasts come in and deposit new material. So this material gets tunneled out. So this is what this looks like. This sheet of material is the calcium phosphate, the ETEX product. This is an osteoclast that's actually eating away the material, dissolving the calcium and the magnesium, breaking it down. And this osteoblast is laying down bone. This is actually new bone formation being secreted onto this surface. So what happens is the body actually remodels this material into kind of like a honeycomb, if you ever seen one of those. And so it gradually replaces it. And this is what the cells look like. Once they get on this material, they actually start changing their shape to actually form the trabecular pattern. So if you look at this, this is how that trabecular pattern is actually formed to regenerate. So the technique, you pretty much make your incision. You can open it or close it. You put your K-wire across, you drill, put your screw in place, you inject your material, and you're done. So it's pretty reproducible. This is one of our first clinical cases, tibial plateau fracture. So you see here. Here's our articular fragment down here where it's depressed. This you can see up here is the kind of the breaks, piece here, a piece there, some pieces there. So we're going to put this all back together. You can see the frontal view there. There's no way that you can put a screw in and hold that in place. For these small pieces, you have to use the ceramic as your support mechanism. So it's got to be put in the right place. You see here, if we don't get cement all the way up to here, then we haven't actually supported the articular surface and it will subside. So this is showing the reduction. We've got a couple of screws in and the plate. Now we're going to put in the N-Force screws. You can see they're kind of a lighter color. There's 2 screws used in this case. And you see this is the material first coming in. And you see what's different with this is the material is going all the way up against the articular surface. So it's supporting up here. In that Nordic example, you showed all the material was down here. Nothing was above the screws. So this implant actually delivers the cement better than just trying to inject it in with a screw. So we're injecting some more material. Now you're getting the idea that the cement is kind of coming around and growing up. We've still got an area up here that we've got to cover. What we found is each screw will handle about 5 cc. So we come down here and we're starting to put some material in through here. So now we're building our construct like this. See, it's coming over to here. And then finally, this took 10 cc's of material. And if you look at this, we now have calcium phosphate cement all the way through this fracture defect. So this reproducibly fills in that defect better than any other technique that we've been able to develop so far. Here's another case of depression of the plateau. Here's the reduction and K-wires to hold it in place. We run the N-Force screws as rafter screws in this case. So here's 2 N-Force screws going in place. Buttress plate is coming on. And now we'll start injecting. You'll see in this model, the cement defect is right through here. You see the cement actually comes all the way over here, away from the screw, and down in this area. So this delivery system of these screws actually helps find where the defects are and fill in those crevices. And as far as the question, does it really get up underneath the articular surface? This was a case that was given to me by Pete Sharkey from Philadelphia. And this is the patient had a total knee, but here's the cartilage articular surface. You can see how thin this is. And this is CarriGen material right up against the cartilage. So this is the only material I know that will actually get up adjacent to cartilage and get close enough to support these fractures. So kind of summing things up, I think we're kind of changing the way we approach these fractures. And the idea is that we're trying to restore that trabecular network. We're trying to get the support of the articular surface in the right place, in the right quantity, with the right amount. And I think this is going to be an exciting area for research. We have some meetings coming up with a lot of guys who are interested in doing some research on this technology. And I think we really have the potential to improve patient outcomes and surgeon reproducibility with these new techniques. So now what I'm going to do is I want to show you this video and just kind of summarize this. This is the way it looks like when you're trying to take, this is Beta-bsm. I'm trying to get it, I fixed the fracture. Now, I'm trying to put it in, and what you're seeing is I can't exactly get the material in. I'm getting resistance. So when I try to inject the material, it's just coming back at me. It's going into soft tissues. And if you look up here, the articular surface is here. I'm trying to support up here. So finally, I get a flush of material right in this area. But I didn't get the material everywhere I wanted. Half of my material has been left behind out in the field. Now, luckily, this stuff is hydration sensitive, so I can wash it off with soap and water, and I don't have to worry about it, hardening up in the wound. But still, I've wasted my cement, and I haven't gotten it where I wanted. So this is actually kind of what we figured out was happening is it's a hydraulic problem. When you have blood and bone marrow inside, when you start injecting material, you get a pressure gradient around this. And this pressure gradient actually forces the material to go back out the syringe. So we can't get into the cavity because hydraulically we can't get rid of the blood and the debris in that area. So it becomes a pressure gradient. So what we're doing with the N-Force system is it's a hydraulic mechanism with these spiral grooves that go through here. The cement kind of comes out, and it's actually pushing the blood and the bone marrow out through the fracture, out toward the ends. And so it changes the pressure gradient so that that helical groove keeps changing the pressure and giving a chance for the blood and the bone marrow to run out the other end. So this is how we're getting this infiltration of the material with the N-Force device. So that kind of concludes the presentation. I think we got some questions. So kind of let's open up that, and thank you all very much. Tim, back to you.
Dr. Russell, thank you very much. Can you hear me okay?
Yes. Yep.
All right. Well, thank you very much. That I've learned something every time we go through that, and I've seen you discuss this topic many times. I'm going to turn it over to Wayne, and then we've got some good questions that have been asked, and we want to kind of go through those. Let me pull Wayne up here and give him a voice. There's always a little bit of a delay, guys, when we kind of switch folks around. But Wayne, take it away.
Hey guys, Wayne Ritchie here. I have to say it's tough to follow Dr. Russell, but I do my best. I just wanted to share with you guys the building blocks of why and how Dr. Russell invented the N-Force system, which is that presentation that we're getting into, and go into how this ties into these studies that we were just discussing. Before I jump to that, I just want to say that 70 to 80% of our customers right now are using allograft. So if you look at that presentation, it's going after that bigger market that I think we can do a little bit better with, get a little bit better outcomes, save them a little bit of time. We've been going after with ETEX, we've been going after competitive products, either calcium phosphates, and I think we stack up well against any of those. But this was mostly going after the guys that are using allograft. So in support of what we're doing and how it kind of ties into and how Dr. Russell saw this, we're looking at literature-based medicine. We have biomechanical studies, we have animal studies, and we have clinical or level 1 evidence supporting this. And I know a lot of guys that are on this conference right now, and I know a lot of you crooks out there. You guys have been selling stuff where it isn't stacked, where we don't have any evidence. I think with this makes our job a lot easier. And just to tie it back in, the biomechanical studies, the one study down out of UCSF showing calcium phosphates or allograft in the proximal tibia, talking about early weight bearing and how much stronger calcium phosphates is. Another key component to that is how close we get to, the subchondral bone, so how close we get to the roof of that tibia plateau. If there's a 5 mm gap, well, then the tibia plateau is going to collapse or subside until it finds that compression-resistant graft. So it ties in there, and then whenever you go into the level 1 evidence and the study done out of JBJS, where it showed that 30% fell without allograft and 9% fell with calcium phosphate. When they went back and looked at those 9%, it showed that they were using less than 5 cc's of graft. And we think that they use less than 5 cc's of graft is because those videos that we show, whenever you're injecting with a syringe and you're trying to get in there, whenever it starts getting pushed out, you're wiping away, you inject it, and you wipe away, they think that void, we believe they thought that void was full, and so they stopped injecting. And so I was just summarizing that to kind of get back to see why this screw fits into these studies and why Dr. Russell invented it and developed it, and here we are. So with all that said, I would like to just jump back to Dr. Russell and Dr. Brown and go over some of these questions that you guys have. You guys have, some questions already, but bring on some more questions. This is good stuff.
Tim, if I can, one of the first things I saw that several times people are asking how much for each screw. You're probably looking at telling your doctor about 5 cc's per each screw. And the reason for that, that's what we disclosed to the FDA when in our testing, that 5 cc's flowed in pretty good and probably got the area that the screw could vent. So if you put 2 close together, you're probably going to have some overlap there. So I like the idea of putting maybe 2 screws underneath the articular surface and maybe 1 down lower if you have a bead defect. And it's going to be variable based on how big the guy estimates the defect is from his CT scan pre-op. But as a rule of materials, what we're finding is we're not wasting any material with the N-Force screws. If we put in 2 screws, we open a 10 cc volume of cement, mix it, and we'll get 10 cc's in there. And I think it just shows us that there was a void that was bigger than we were guessing by just injecting. And now that we've got the screw in there and better delivery, we're seeing much better filling patterns of this whole defect. So I think that's one of the nice things is we're not wasting the material and it's going in the right place.
Tony, would you like to address the question about using beta versus CarriGen, or would you like me to field that?
Go ahead.
So you all know Dr. Russell just explained that the FDA cleared both beta and CarriGen. Beta, as you all know, has 30 megapascals of compressive strength, where CarriGen has around 10 megapascals. So obviously, in these defect type situations, it would be better to use the higher compressive strength material. The other benefit of beta is that it has the syringe-to-syringe mixing system, which makes it way more convenient. Currently, with CarriGen, you've got to mix it in the bowl and then stuff it into a 1 cc syringe and then inject and stuff some more into a syringe and inject. So we know that ETEX is working on an initiative right now for a different mixing system. You also probably have heard that CarriGen contains a molecule, CMC, which is basically a lubricant. We kind of think of it as a lubricant that, if you held beta in your hand and CarriGen in your other hand and compared the two, you would think that the beta, being a little bit runnier, thinner, would flow through the trabeculae better. But actually, the opposite is true, that the CarriGen, having that molecule in there, it actually will kind of self-lubricate itself through the trabeculae. Now, beta still flows through trabeculae, but the CarriGen has a little bit more flow when compared to the beta. So, for example, if I was doing an ankle fracture, for example, and maybe putting 2 medial screws up with the medial malleolar fracture, there's no defect, that would be a perfect place to use CarriGen. Now again, because of the mixing system, I probably would choose to use beta at this point. So we know that probably 99% of our cases are going to be beta, but when there is a new mixing system for the CarriGen, that sort of case would be a perfect augmentation of those medial screws. While I'm chatting, let me just tell you a couple other things. We've had this discussion about why we think that there's such a prominence of use of the allograft autograft. And I was telling Wayne the other day, I said, you know, I really think that the problem has been is that through residency, through our training, you know, at meetings, it's kind of beat into our head that autograft is the gold standard. Now, in some fractures, like in a diaphyseal fracture or a non-union, that's absolutely the truth. But in these peri-articular fractures, what we're trying to change is that's not the gold standard, and really the calcium phosphates should be the new gold standard for these peri-articular fractures. The other comment that we've gotten from a number of surgeons, or from a few surgeons, is you know, I think all my tibial plateaus do fine. I use autograft, and I really think they do fine. My suspicion is that most guys like myself or Dr. Russell will see folks back for 6 months, and if you're not doing a study, you know, you get an x-ray, things look healed, they're walking, they seem to be happy, and you release them, and you walk away as a surgeon saying, you know, I think all my tibial plateaus do fine. The fact of the matter is, I think that a lot of these are probably coming back at a year or two or more with that post-traumatic arthritis. We attribute that to the injury itself and not to the collapse. And that's where we're trying to get people to look at the scientific research and say, look, even though you think that they all do fine, probably not. Probably at least 30% or more of these are collapsing. So Tony, back to you.
The next question about the plates. So just so you guys understand, our plan is eventually that we're going to have more than one screw, and we're going to have other implants. So when we design this, it doesn't really fit anybody's plate perfect. And that actually was something the FDA was concerned about. So the screw doesn't go through anybody's plate perfectly or attach it. There are some plate holes that are big enough that you can put the screw in. But it's not attaching to the plate. It's just going through the hole. So I've got a plate here, I'll put it in the camera, and it's a Synthes tibial plateau. It's a non-locking. And if you look at those top holes, a lot of times the screw will actually fit through those top holes. And it's not holding the plate down. It's just an access portal. In the Peri-Lock system, we have scallops at the top, and we'll actually put the N-Force above the scallops to get them up close. I think that in the future, there probably will be N-Force designs that do attach to plates, but that's not yet.
As I read down through some of the other questions, Steve, you've asked, could you give an approximation of how much calcium phosphate average volume you're using in these type of defects? And that's really, that's hard to give a number because you know, these fractures have all sorts of different characteristics. The defects are all different sizes. The ones that I have been seeing come back, probably somewhere between 10 and 15 cc's of beta in the defects. But again, that's just talking tibial plateaus. It's going to be different for proximal humerus or a calcaneus or an ankle.
I got a question about the issue of the costs and the skin screws are all around. So really, see, the first thing in most of the United States, trauma implants like tibial plateau fractures and calcaneus fractures, the trauma implants are not capitated like total joints. And so unless you really know what's going on in your hospital, in your area, and you kind of have to ask your doc about this, typically hospitals get about 3 to 4 times markup on screws, plates, and those kind of things. So I know they harass you guys pretty hard about knocking your price down, but they actually make money on these things. So we did present it to the military, and the military thought that the cost ratio was okay. And I think that it really comes down to you got to put things in reference to what a hospital day is. A hospital day is about $3,000 to $4,000. So you may argue it's $3,000 or $4,000 too much for a hospital day, but that's what the hospital charges. And I think that that's kind of the line of these things. The real question is, if we use these cements, are we going to have to use as big of plates, or are we going to have to use as many screws? So we actually might look at the total construct price going down, but that's all hypothetical. So I think the cost issue, people are going to raise it, but I think if you really get down to it, the benefit it offers to the patient, I think offsets that. And I think if the hospital gives you a hard time, you might just ask them and say, listen, if you show me what you reimbursed, then we'll make a deal. And I think you'll come out okay on that. I'm sorry.
Oh, Hugh was asking if we are going to do a presentation like this at the Academy. Of course, we've got a InnoVision ETEX booth, and we certainly encourage all you guys to bring your physicians by. We're not going to do a presentation like this at the Academy, but we will plan on doing one, another one for our team. Apparently some of the guys had a hard time kind of getting signed in tonight. I apologize for that. But we're going to do another one March 13th. At 7 o'clock. That again will just be our team for sales, no physicians, but we will plan on doing one that we invite physicians soon after that.
A question about the mechanics of the screw, and Terry Powers and NASO was asking about those. So if you want to explain this to your surgeon, these are equivalent to all the 4 Kinley screws on the market as far as strength. It's right in the middle of all of them. The reason we were able to do that is that the design of the screw, if you know what an I-beam is, like in your building skyscrapers, you put an I-beam in, it's a piece of metal that has holes cut in it. But the strength is still good because the outer perimeter is intact. So what we did, the screw is a twisted I-beam. And so the I-beam type shape allows us to spread the forces under it to keep it as strong as a regular screw. And the helical design with the holes and the internal diameter is a hydraulic equation to allow you to optimize the flow of the materials out without it using too much pressure. One of the big concerns that the federal government had was they were afraid of deaths from high injection pressures of these materials. And what we showed them is that the screw is actually calibrated hydraulically to be the force required for digital insertion by a right-handed 120-pound woman. So it's viewed as safe from that standpoint. And that was another one of the criteria for the FDA as far as safety for clearance of this device. I think we've
Tony,
got about, go ahead.
Tony, would you mind answering Nasso's question? He said, how would you position the screw for elective orthopedic procedures? I know this is really meant for more trauma applications. We do have a 7.0 screw on the drawing boards that will be used possibly around acetabular cups and those sort of things, but do you have any other suggestions as far as when these guys are trying to sell to their docs about any other elective type cases?
Well, for elective cases, you need to ask questions like the first one that I hear talked about a lot is that in the total hip surgeons, they frequently have lytic lesions behind the cups, but the cup is still okay. And they can pop out the liner, but then how do they get the material in behind the cups? And so, I think it's pretty easy to take a 4.0 screw, put it around the liner or even through the metal shell and inject your material in there. And that gets you a much more uniform insertion of materials. I think as far as the other elective cases, it had to be a defect thing. So like some simple bone cysts in the calcaneus or humerus, it'd be a good indication for that. But the elective type procedures, we're also playing with the idea of suture anchors. that you can anchor in place with these materials and give them much stronger than what's currently available on the market. But all these things are kind of going to come, you know, one step at a time.
George, you asked a couple questions, and it wanted to give you a couple little tips and tricks while doing this. We've learned that sometimes when you take the screw and you put it all the way into the bone, and there's a little bit of soft tissue sleeve there occasionally on the bone, a little periosteum, you can be fooled that the sheath is not all the way down to the cortex. Now that first hole is fairly close screw, and so if it's not seated all the way down, you will get a little bit of cement coming out. So if that's the case, obviously the surgeon needs to drive the screw in just a little bit further. But just, you know, when they're first putting them in, make sure that they drive that all the way down to the cortex. The other thing we've had, I think just one of these, but one of the surgeons asked the scrubs to mix the beta probably about 20 minutes or so before injecting. And we want to just encourage everybody that, you know, don't mix and then set it on the back table, because there's going to be enough dehydration in the cement that it could actually plug the screw as it's going in. So make sure that they've got all the N-Force screws set. Mix the cement and then use it right away.
So there's a question from Steve Zimmerman about the screwdriver. And part of the hydraulics in the thing was to open up that internal diameter. So your best thing, if you have a screw that needs to be removed, you need to call your rep, because the screwdriver is not a standard size. It's not a small fragment screwdriver, and it's not a large fragment screwdriver. So it really pretty much is a custom size screwdriver in the set. I think we have some sterilizable hex wrenches. So if you had a Allen wrench set, you can sterilize that. You can take it out with that. But it's not a standard size screwdriver. And that, again, is because of the hydraulic equation for the screw.
Charlie, you asked when would be the indication using the fully cannulated screw. I imagine that the other side of that is when to use the partially cannulated. If I'm going to go bicortical and go all the way across, I'm going to use the partially cannulated, so I'm not risking any danger of having the cement come out the very tip of the screw. We're very curious of where the distribution is going to be, whether guys are going to use more the fully cannulated or the partially cannulated. If your screw stops within the bone, within the metaphysis, then I would definitely be using the fully cannulated, because you can put it over the K-wire. It makes it a little easier.
I guess some of the tips that I want to pass on from our guys in Arizona who had their first case on Friday. First of all, the guys that have been using calcium phosphates are used to a lot more back pressure. So whenever they inject with the syringe, they don't need all their weight or force behind it. As Dr. Russell said, a 120-pound woman using 3 fingers. And then if they have created a window, if they have created a window to get to that tibia plateau to elevate it, you're going to want to plug that window before you inject. So that's just something that came from our case on Friday.
Mike, you asked when the tibial plateau collapses. Yeah, all the above. And you know, this is a part that I'm really excited about. You know, sourcing this out clinically. We've got some good studies that we're going to get designed soon and get rolling. But there's a number of studies that are showing that people with stable fractures have less pain. And that includes these peri-articular fractures. So if we've stabilized all those parts and pieces, they're going to have considerably less pain. When they get collapse, yes, they get pain. they begin to have symptoms of arthritic knee, basically. So that's what you would expect to start seeing. Tony, would you mind answering Terry Powers? He said when treating a tibial plateau and anticipating using 2 screws, would you recommend opening a 10 cc syringe or 2 5 cc syringes of beta? If you lose reduction or have to adjust your fixation, will it affect your ability to inject the beta-BSM?
All right, so let me tell you how the technique I use. I'll go ahead and put the N-Force screws in. For the rafter screws, I'll put the plate and screws on. So I've got all my fixation in place, and then I'll inject the material last. Because you don't want to be injecting material and still trying to reduce things. So you want everything stabilized before you inject your material. And we had a case just last week where they mixed the cement early and had to go back and do some things, and then the cement was almost setting up, or dehydrating, so it wouldn't flow in easily. And luckily, it was an acetabular fracture. They were using it for a posterior wall defect, and they got it in. But that was the first time the guys realized they couldn't just sit it there forever. So I really think that you ought to get all your fixation right, get it in place, get some x-rays, and be mixing the cement. And then while you got the C-arm in the room, start injecting the material and watch it flow in there. We've been surprised. It's just about always 10 cc's for plateau. There's been occasions where we needed 15 cc's. So when you start looking at these CT scans and get a little more experience, you'll start realizing that these defects are actually bigger than we thought they were. It's just that we couldn't get the cement in there. We didn't realize how big they were. 10 cc for a plateau is what I'm opening now. I think it's cheaper that way.
Now, so you were asking about indications for podiatry. A lot of the podiatrists are kind of moving up the foot and ankle a bit. Of course, about the ankle and the pilon fractures. I could see this used in a fifth metatarsal fracture, like a Jones fracture. In fact, we've done some cadaver work with that, calcaneal fracture. Our pat answer has always been wherever they can use a 4.0 screw, and they need augmentation.
I want to thank you guys for having some great questions. The discussion thing is really, really interesting to watch. I think this is really helpful for me to see what you guys are thinking and the questions. So thank you for continuing to type questions into the chat room.
Terry had asked us earlier just to go over some of the features with the screw. Do you want to talk about that, Dr. Russell? Or, the hydraulic groove, the measuring from tip to tail, the threaded head, partially cannulated, fully cannulated? I guess I can.
Okay, so basically, again, it's a four design. It's 25 millimeters is the shortest, and the longest is 75. So it's 5 millimeter increments. The K-wire is a 1.6 K-wire that's in the set for the cannulated. And we use the cannulated technique, and then we make a decision. If it's got bicortical, then we'll put the partially cannulated screw, pull the K-wire out, put the partially cannulated screw in. If it's really inside the bone, not penetrating the other side, then we'll go ahead and insert it over the K-wire. The biggest error we find learning out is the guys start putting the sheath down, and they think it's all the way down. It's not. So if you start injecting material and you see material coming out around the bone sheath interface, it means the screw is not all the way in. So you put your screwdriver back in, turn it 2 more times, and then put the cement in, it'll go. You shouldn't inject a screw, wait 5 minutes and come back and try to inject it again. The cement will already start changing, and so you won't be able to inject. So you pretty much need to finish the 5 cc's in one screw and move to the next screw and put 5 cc's in that one. And don't try to go back and forth between them. The helical groove is not only the hydraulic thing, but also a strength thing. And if you'll notice on the screw design, the holes for the cement to come out are at the bottom of the helical groove. And that's one of the ways we got our strength up to speed on the screws. That's pretty much You probably, we talked in the technique that once you inject the cement through the sheath, you should take a solid screwdriver and push the cement in to clear the sheath. And that does two things. Number one, you don't waste that extra cc of cement, but you also clear out the cement in the head of the screw. And the helical groove, that's the hydraulic strength key, is also the extraction key. So once that cement hardens or if bone grows into it, you can put a screwdriver back in that screw, and with hand pressure, you can shear the screw out and cut a tapped hole in the cement column. So it's one of the safety features, again, is even when the cement hardens, you can still extract the screw without any special instrumentation. So that's kind of just some of the tips and some of the features inside.
Shane, you asked if this is recorded. We have recorded this, and we're still trying to figure out. It comes out as a very large file, and so we may end up trying to put it on a little stick drive or something like that. But later on, we will have this available. Don, you're asking how does a surgeon know the defect is filled? Should CP be injected until it's visible outside the bone? And your answer to that is the surgeon should be watching on the C-arm. That's when you're really going to know the fill, and that's really the beauty of the N-Force, is that you keep the product inside the bone. We really, we don't want to see a bunch coming back out. You should, of course, the surgeon should carefully watch the C-arm and watch it come up to the subchondral bone, and making sure that it's not going into the joint. We've talked about this a lot to a lot of you guys. What happens if they did see it go into the joint? This cement can be overhydrated, so it does not set up in the joint. You can actually inject the joint with some sterile saline and flush it out if concerned about that. Yeah, the surgeon will be watching it by C-arm. Let's see. I want to make sure that we get down to Jay. Distal radial fractures were mentioned earlier. Can you go over the technique? Thus far, nobody has put it into a distal radius, but we're looking forward to that. We've got a number of hand surgeons that have talked about it. What they're talking about is putting a single screw down the radial styloid. Of course, it's got to be a fracture that is amenable to kind of a one screw fixation. They'd reduce the fracture, put the screw down the styloid. Of course, it would have to be buried into the styloid as the screw, as you know, the screw does already. Then the calcium phosphate would be used to backfill the fracture there. So some of these fractures, we'll get more information as we go. And let you know, what the experience with in some of those areas are really like.
Hey, I have a question for everyone that they can kind of answer. Do you want references of these articles, or do you want abstracts? It's kind of hard to get the exact paper because of copyright laws. So would a reference with an abstract be adequate for your doctors? All right, that's great.
Lots of good comments on here. Ben was talking about mixing the beta and just making sure that the syringes are attached, so you're not getting that dehydration at the end of the syringe. Well, I think we're probably kind of wrapping up here, guys. I know there may be more questions, and feel free to contact Wayne or myself. We just so appreciate everybody's input. We appreciate what you guys do, and we know that, again, you're on the front line. So we want to give you all the ammunition that we can to sell these things. We hope that this webinar was helpful. Once you guys sell a gob of these, we may have a sales meeting in Montana one of these days. So we'll look forward to that.
In the summer.
In the summer, that's right. Tony, do you have anything else to add, or Wayne?
I just want to thank everybody. Tim, thank you for getting us together and keeping us electronically savvy. And Wayne, thanks again for keeping us organized.
Thank you, guys. Thank you for everything. I appreciate all of your times. All of your